A 50 years old right-hand dominant comes to your clinic with numbness and tingling down the ulnar aspect of the left forearm and hand. Complains that increasing activity increases his symptoms. It is worse early in the morning and does improve in the daytime. It does not affect his activities of daily living. Start examination. There is no apparent forearm or hypothenar wasting of the upper extremity. Range of motion of the elbow is 0 to 125 degrees. Area were examined for any tenderness around the course of ulnar nerve or any subluxation. There was tenderness in deep palpation over the cubital tunnel, but tunnel sign was negative at the cubital tunnel, carpal tunnel, or the Guyon's canal. Patient was examined for abduction of the small finger with extension, that is Waterberg sign, which was negative. Earl test was also negative. Grip strength was optimal and intrinsic muscles had a power of 5/5. Sensory examination did show paresthesias of the fifth digit and another aspect of the fourth digit. 2-point discrimination was more than 10 mm in the fifth digit. A diagnostic test in the form of EMGs were done. MRI can help in the diagnosis as well. AP and lateral radiograph showed no abnormalities, while it is important to do the X-rays, specifically in history of trauma. Carpal tunnel projection also can help to exclude any osteophytes at the level of cubital tunnel. What is the diagnosis? The differential diagnosis can be cervical spine arthrosis, cervical spine disc disease, syringomyelia, thoracic outlet syndrome, Pancoast tumor, ulnar nerve entrapment in the Guyon's canal, or cubital tunnel syndrome. Our case was a case of cubital tunnel syndrome. Cubital tunnel syndrome is a dynamic nature, and the nature in pathophysiology understanding has improved its diagnosis. After the appropriate history and examination, the diagnosis of ulnar nerve compression can be made. In addition, a thorough physical examination and electrodiagnostic testing can be of greater significance for definitive diagnosis. In our case, EMG and nerve conduction studies revealed compression of the ulnar nerve at the level of cubital tunnel with sensory distribution. The elbow flexion test is the most diagnostic test for cubital tunnel syndrome. The test involved the patient flexing the elbow past 9 degrees, supinating the forearm and extending the wrist. Results are positive if discomfort is produced or paresthesia occur within 60 seconds. In addition of shoulder abduction may enhance the diagnostic capacity of this test. Conservative management of cubital tunnel syndrome is often successful with complete resolution of symptoms. Symptoms can also be reduced by avoiding the activities that contribute to the nerve compression. This may include avoiding flexing the elbow and resting on the elbow. The patient can be placed in a long arm splint with the elbow flexed to 45 degrees. The splint is worn for about 6 weeks. Activity modifications can help to relieve the pain. Oral anti-inflammatory can be helpful. If the non-operative modalities fail in 6 months, surgical options should be thought of. For surgical management, the patient is positioned supine on the operation table and the upper extremity is prepped and draped in a usual sterile fashion. IV antibiotics are given. A sterile, well-padded tourniquet, which is high enough, is inflated to 250 mm Hg following exsanguination. The incision is marked out carefully to avoid injury to the medial antebrachial cutaneous branch. Incision is made medial as surface of the elbow beginning 10 cm proximal to the epicondyle and extending distally about 15 cm. Subcutaneous tissues are sharply dissected until the two heads of FCU are identified. At this point, the arcuate ligament of Osborn may be visualized, divided, revealing the ulnar nerve in the cubital tunnel. To fully explore the ulnar nerve, the insertion of FCU has to be dissected from the epicondyle. The articular and muscular branches, that is to FCU and FTP, are identified and dissected. Vessel loops can be placed around the ulnar nerve, which is removed from its bed and reflected anteriorly. The nerve is freed from surrounding soft tissue with a no-touch technique. The medial intermuscular septum is released proximally to the arcade of Struthers. A trough is then made 3 cm from the medial epicondyle in the flexor pronator mass. The ulnar nerve is then placed in a trough and the overlying muscle fascia is loosely reapproximated. The elbow is taken through the range of motion and no compression is noted. The wound is copiously irrigated with normal saline. Tourniquet is deflated and hemostasis is secured. Skin is closed and sterile dressing applied. The arm is splinted till 45 degrees of elbow extension, fully pronated, and 15 degrees of wrist flexion. The splint is intermittently used for about 6 weeks. At 2 weeks post-op, the patient begins range of motion exercise, and 6 weeks the patient is without any complaints or symptoms. The patient is allowed to do sports at about 4 months after the surgical intervention. There are many alternates to the methods of management. Alternative methods can be in situ decompression, medial epicondylectomy, or anterior transposition of the ulnar nerve. Each method has disadvantages and disadvantages, and none is clearly shown to be superior. The medial epicondylectomy removes the floor of the cubital tunnel. This procedure consists of osteotomy of the epicondyle and reattaching the flexor pronator mass to the surrounding soft tissue. Various techniques of anterior transposition of the ulnar nerve has been described. The nerve is completely removed from the tunnel, therefore eliminating any potential sites of compression. Subcutaneous transposition involves the creating a sling in the subcutaneous tissue. The ulnar nerve is removed from its bed and is protected with the sling. A second method of transposition consists of placing the nerve in the intramuscular trough of the flexor pronator mass. It is important that the fibrous septa of the musculature is removed to prevent adhesion formation. In submuscular transposition, the ulnar nerve is positioned beneath the flexor pronator mass. There are complications of surgical intervention. They generally include persistent symptomatology, elbow instability, medial antebrachial cutaneous neuroma, painful scar, or reflex sympathetic dystrophy. The recurrence of preoperative symptoms may be due to scarring or adhesion formation, in situ decompression, or transposition. In each case, recurrence is possible. In addition, failure to release all potential sites of compression will resist in persistence of symptoms. This most frequently occurs proximally at the arcade of Struthers and the medial intramuscular septum.